Welcome to our 100th episode of Conversations with Dr. Glogauer and Kim Ivan. Dr. Glogauer, can you believe that we've done 100 or will be doing 100 episodes?
Well, it's pretty amazing, Kim, because I believe we started this during the very, very first months of COVID,
I believe you're correct.
2020. So
I believe you're correct.
it's been more than 3 years.
Yeah.
And yeah, so it's been an exciting journey.
So what have been some of your favorite topics?
Well, we've covered so much. And, if I had to give a general overview of what my favorite topics is, I definitely am biased because bringing home or bringing to the amazing hygienists of Ontario the research that we've been generating in our lab, the knowledge translation, has sort of been the things that get me the most excited. But we've certainly talked about almost everything under the sun, I think.
Oh, I think there's a few more topics to still cover. I've enjoyed, there's so many that I've enjoyed, some of the ones we've really delved into: osteoporosis, cystic fibrosis, cardiovascular disease. And I, as well, enjoyed talking about your research and interviewing our guests on, the research that they've participated in with you and learning about all what goes on behind the scenes of a study. So we hope that everybody listening has enjoyed the audio cast as much as we've enjoyed producing them. And as a reminder, with each audio cast, we provide keynotes, which cover everything we talk about, so you don't have to take notes unless you really want to. And we also provide extra resources to enhance your learning. And depending on the topic, there's usually some client resources to help implement your changes into your dental hygiene practice. And today, our topic is antimicrobial resistance. So antimicrobial resistance, or AMR, occurs when bacteria, viruses, fungi, and parasites no longer respond to antimicrobial agents. As a result of drug resistance, antibiotics and other antimicrobial agents become ineffective, and infections become difficult or impossible to treat, increasing the risk of disease spread, severe illness, disability, side effects from using multiple or stronger medications, and it can even result in death. The World Health Organization, the WHO, has listed antimicrobial resistance as one of the top 10 threats to global public health. AMR threatens to return us to a time when we were unable to easily treat infections such as pneumonia, tuberculosis, gonorrhea, and salmonella. The inability to prevent infections can seriously compromise life-saving procedures such as chemotherapy, organ transplantation, cesarean section, and hip replacements. The drug-resistant infections also impact animal and plant health, farm productivity, and food insecurity. Antimicrobial resistance has significant costs for both healthcare systems and national economies. For example, it creates a need for more expensive and intensive healthcare, affects the productivity of both those affected and their caregivers through prolonged hospital stays, and decreases agricultural productivity. It's a problem for all countries at all economic levels. Its spread does not recognize country borders. People living in low resource settings and vulnerable populations are especially impacted by both the drivers and the consequences of antimicrobial resistance. And this is not a new phenomenon. For example, after the introduction of penicillin in 1943 for the treatment of often fatal bacterial infections, resistance was observed for Staphylococcus aureus by 1948. And in 1961, methicillin-resistant Staphylococcus aureus, MRSA, or MRSA, was observed approximately 1 year after its first clinical use, and rates of MRSA infection increased rapidly between 1990s and the early 2000s. So combating antimicrobial resistance is a global endeavor, and it must be addressed through a One Health approach. And One Health is a multidisciplinary approach to achieving optimal health for animals, humans, and the environment, and recognizing these three sectors are intimately connected. And in the keynotes, we provided a chart of just some of the pathogens that are now considered antimicrobial resistant. So Dr. Glogauer, tell us about some of the stats.
So AMR contributes to almost 5 million human deaths from bacterial infections alone each year. And in 2019, bacterial AMR was directly responsible for almost 3 million deaths worldwide. So without intervention, AMR could result in up to 10 million deaths a year globally by 2050. And moreover, this burden falls disproportionately on low and middle income countries, exacerbating global health inequalities. And because approximately 26% of bacterial infections are currently resistant to first-line antimicrobials, it's estimated that resistant bacterial infections were responsible for the death of over 14,000 people in Canada in 2018, so 1 in 19 deaths. And of these deaths, almost 5,500, or 15 a day, were directly attributable to AMR itself. So this is a serious threat in Ontario, with an estimated 6 lives lost every day due to AMR infections, and approximately 1 in 4 antimicrobial courses prescribed to Ontarians is considered unnecessary. Bloodstream infections caused by AMR bacteria increase the odds of death by 30% compared to antibiotic-susceptible bacteria. In addition to death and disability, AMR has significant economic costs. And the World Bank estimates that AMR could result in $1 trillion in additional healthcare costs by 2050, and 1 to 3.4 trillion gross domestic product losses per year globally by 2030. So this is an astronomical amount of added healthcare burden. And the cost of the Canadian healthcare system and Canadian GDP are already significant, with an estimated $1.4 billion cost of the healthcare system and $2 billion in GDP, respectively, in 2018.
So certain populations in Canada have an increased risk for acquiring infections, and then in turn are also at an increased risk for antibiotic resistance. At-risk groups include infants, especially premature infants, because of their underdeveloped immune systems, older adults, particularly those living in long-term care or senior residences, because they may be exposed to more infections, they're living in close contact with many others, and they may have compromised immune systems due to illness or extended antibiotic use. There's also people who are homeless or living in crowded or unhygienic conditions where it's easy to come in contact with infections, and then also people with compromised immune systems. The greatest risk factor for acquiring a resistant infection is previous antimicrobial treatment. At-risk groups based on behaviors and settings include people in healthcare facilities, daycare centers, and other settings where infections can easily spread, especially if they're not following proper IPAC measures. People who do not practice good infection prevention control behaviors, for example, they're not following good hand hygiene. Those who do not store, handle, or prepare food safely. People with substance use disorder, and those who have occupations that put them at greater risk for exposure to bacterial or infectious diseases. For example, healthcare providers, veterinarians, slaughterhouse and meat processing plant workers, and farmers. So what are some of the mechanisms of resistance?
So AMR is a natural process that occurs over time through adaptive evolutionary genetic changes in the bacteria that enables them to withstand antimicrobials. And these genetic mechanisms give rise to resistance because they result in a biochemical modification that can alter certain bacterial cell properties that normally render the cells sensitive to an antibiotic. So for example, these biochemical modifications include production of enzymes that inactivate the drug, activation of drug efflux pumps that will pump the drug out of the cell, alterations of bacterial cell drug targets, alteration of the protein, enzyme, or the receptor targeted by the drug, and alteration of cell wall proteins that inhibit drug uptake into the cell. So genetic mechanisms that can give rise to antibiotic resistance are mutations and acquisition of new genetic material. So mutation is the rate at which the resistance develops, can be attributed to the rate at which the bacteria mutate. Mutations occur naturally when cells divide. Bacteria are especially prone to mutations because their genome consists of a single chromosome and because they have a high rate of replication. The more replications a cell undergoes, the higher the chance it has to mutate. You can acquire new genetic material, which appears to be the most common mechanism by which resistance develops. And it is facilitated by the fact that bacteria are prokaryotic organisms, which means they don't have a nucleus protecting the genome, and by the presence of small pieces of DNA called plasmids that exist in a bacterial cell that separate from the chromosome. And thus the genetic material of the bacteria is free floating within the cell and making it open to gene transfer, where that genetic material can be transferred through to another cell. In nature, the primary mechanism of bacterial gene transfer are transduction and conjugation. And transduction occurs when a bacterial virus called a bacteriophage detaches from one bacterial cell, carrying with it some of the bacteria's genome, and then infects another cell. And when the bacteriophage inserts the genetic material into the genome of the next bacterium, the previous bacterium's DNA also is incorporated into the gene. So if there's any antibiotic resistance genes are then transferred from one bacterium to another. Conjugation occurs when two bacteria come into physical contact with each other and a plasmid is transferred from the donor cell to the recipient cell. So this is more of a direct transfer from bacteria to bacteria. And the plasmids often carry genes encoding enzymes capable of inactivating certain antibiotics.
So the emergence and spread of AMR are accelerated by human activity, mainly the misuse and overuse of antimicrobials left over to or to treat, prevent, and control infections in humans, animals, especially those animals that are in food production, and plants. So examples of antibiotic misuse include giving antibiotics to people and animals when they're not needed, taking antibiotics in ways that were not prescribed, taking it in different ways, self-medicating or antibiotic sharing, and taking antibiotics for an infection not caused by bacteria. So you don't take an antibiotic to treat a viral infection. Other contributing factors include inadequate access to clean water, sanitation, and hygiene for both animals and humans, poor infection prevention and control practices in healthcare facilities, homes, and farms, limited availability to quality, affordable vaccines, medications, and diagnostics, and we'll talk more about vaccines soon, inadequate awareness and knowledge among healthcare providers and the public, and inadequate enforcement of legislation to regulate antimicrobial use. So tell us about the study by Ota et al.
So a systematic review and meta-analysis was published by Ota et al. In 2019, and it was on the global access to antibiotics without a prescription. And they showed across 38 studies from 24 countries that the pooled proportion of non-prescription supply of antibiotics was 62%. So non-prescription supply of antibiotics was highest in South America. And the study demonstrates that antibiotics are frequently supplied without prescription in many countries. And this overuse of antibiotics can facilitate the development and spread of antibiotic resistance. According to a survey in 2022 by the WHO in the European region, that showed that a third of people in 14 countries, mainly in Eastern Europe and Central Asia, used antibiotics without a medical prescription. In some of these countries, more than 40% of the antibiotics were obtained without medical advice. In contrast, the equivalent survey conducted in the European Union in 2022 revealed that only 8% of the participants consumed antibiotics without a prescription. And the survey involved over 8,000 participants, half of whom reported taking oral antibiotics in the past 12 months. And the reasons cited for taking the antibiotics include colds, flu-like symptoms, sore throat, and cough. And these are often caused by viruses unaffected by antibiotics. Overall, almost 85% of the participants showed a lack of knowledge about the appropriate antibiotic use. Only just shy of 40% reported receiving any information in the past year about the importance of avoiding unnecessary antibiotic use. And almost just over 20% held the misconception that antibiotics can be stopped once they start feeling better. Among respondents who experienced COVID-19, almost 30% took antibiotics without a prescription, while 8% took antibiotics, almost 30% took antibiotics with a prescription, while 8% took antibiotics without a prescription. Medical expertise is essential to making a correct diagnosis and determining whether the antibiotics are the right course of treatment. The research clearly highlights the need for education and raising awareness about antibiotics. All countries in the region have regulations to protect antibiotics from misuse. So, for example, preventing over-the-counter sales without a prescription. Enforcing these regulations would help prevent antibiotic misuse among humans. Proactively addressing these challenges can foster a culture of responsible antibiotic use and make major strides in global efforts to combat the threat of AMR.
So personal beliefs and healthcare system barriers contribute to inappropriate antibiotic use. And this was reported by researchers who presented at the ID Week 2023 annual meeting. And this meeting, they present peer-reviewed presentations of new research. So Shaw and colleagues conducted a cross-sectional survey of just under 600 patients at 6 primary care clinics and 2 emergency departments in Houston, Texas, to identify motivations to use antibiotics without prescription. Non-prescription antibiotic use among the participants included using antibiotics left over from a prior prescribed course, antibiotics obtained from social networks, or antibiotics purchased over the counter in other countries or illegally in the US-based stores and markets. So participants primarily reported using antibiotics for symptoms of COVID-19, influenza, and the common cold, and we know these are viruses, as well as for pain management, allergies, and even wounds. So participants used antibiotics to treat symptoms they previously had or because they believed they understood their illnesses and which medications would be the most effective for their bodies. Some participants used antibiotics as an alternative to over-the-counter medications they perceived that were ineffective. So participants documented barriers to healthcare and treatment access, including long wait times to schedule appointments and long wait times to see the doctor while they were at their appointments. Participants struggled with getting transportation to their appointments, paying for parking, and affording the associated costs with doctor appointments. Many participants opted to use non-prescription antibiotics because these antibiotics were more convenient than visiting a clinician and are easier to obtain and afford. The study highlights the importance of providing education on safe antibiotic use, providing alternate treatment options for everyday symptoms, and working to improve access to healthcare and related services. So tell us the impact the COVID-19 pandemic has had.
So the pandemic may have exacerbated AMR. A rapid review of meta-analyses by Langford et al. In 2021 found the proportion of individuals with COVID-19 receiving an antibiotic was approximately 75%, despite the viral etiology of COVID-19 and the low bacterial co-infection rate of about 3.5% and secondary infection rates of only 14%. Unnecessary antibiotic use was likely to be high in individuals with COVID-19. Now, antibiotic overuse was common when initial etiology was uncertain, while waiting test results and when there were concerns about possible co-infection, even once SARS-CoV-2 was identified. Further efforts to address COVID-19 disrupted antimicrobial stewardship programs due to redeployed staff and competing tasks such as addressing drug shortages, acquiring therapeutic agents, and developing COVID-19 guidelines. A recent systematic review indicated that as many as 60% of individuals that had bacterial infections and COVID-19 harbor an antibiotic-resistant organism. In 2022, a special report from the U.S. Centers for Disease Control and Prevention found 15% increase in AMR in a number of microorganism species, including carbapenem-resistant Actinobacter, MRSA, carbapenem-resistant Enterobacteres, or CRE, multiple drug-resistant P. aeruginosa, which is a major issue in pneumonia, and antifungal-resistant Candida auris associated with the pandemic.
So it's also important to consider the role of dentistry plays in antimicrobial resistance, since dentists prescribe 10% of all antibiotics dispensed worldwide, and research has shown up to 80% of antibiotics prescribed by dentists may be unnecessary. In a 2018 systematic review, they found dentists regularly prescribed antibiotics for inappropriate purposes, such as administering prophylactic doses in healthy clients, treating oral infections with systemic antibiotics when localized treatment would suffice, prescribing antibiotic prophylaxis for cardiac conditions that the guidelines no longer include, they're no longer included in these guidelines, prescribing antibiotics to clients who were uninsured rather than completing recommended surgical treatment because of affordability issues. The study provides insight into the importance of antibiotic stewardship in the oral health setting and encourages dentists to reflect on their antibiotic prescription practices. And I'll refer you to episodes 23 and 37 when we discussed prophylactic antibiotics for artificial joints and cardiac conditions. A study done in 2023 found no change in U.S. dental antibiotic prescribing rates from 2012 to 2019, despite changes in guidelines and decreases in medical antibiotic prescribing nationally. During the study period, 216 million antibiotics were prescribed by just under 250,000 dentists, with a majority going to male clients, and those clients aged 40 to 64 years. And amoxicillin and clindamycin were the most frequently prescribed antibiotics, which made up, amoxicillin was about 63%, and clindamycin was about 14%. The average provider, the average provider-based prescribing rate for all antibiotics was over 140,000 prescriptions per 1,000 dentists per year. Dental specialties, especially oral and maxillofacial surgeons, had the highest prescribing rate, with increases over time. The authors concluded antibiotic stewardship efforts to improve unnecessary prescribing by dentists and targeting dental specialists may decrease overall antibiotic prescribing rates by dentists. So tell us about the 2017 survey of Canadian dentists.
So this survey indicated that there was a misunderstanding by dentists on both cardiac conditions and the dental procedures requiring antibiotic prophylaxis to prevent infective endocarditis. Then there was also a lack of awareness of changes to these guidelines for total joint replacement, variation in prescribing practices among dentists for antibiotic prophylaxis for the prevention of surgical site infections, the use of antibiotics for conditions where antibiotics were not necessary, and general overuse of clindamycin and underuse of penicillin V. And it's important to note that overuse of clindamycin, which is a broad-spectrum antibiotic, can promote AMR and C. difficile infection. To minimize use of clindamycin, clients can be encouraged to get tested for penicillin allergy, considering a true penicillin allergy is very rare. Now, recent data shows that more than 80% of antibiotics prescribed for prophylaxis before oral health visits were unnecessary, despite guidelines limiting antibiotic prophylaxis to very high-risk individuals. Inappropriate antibiotic prescribing for oral health appointments costs millions annually, according to a modeling study by Gong et al. In 2023. And the researchers estimated that the costs associated with this practice and assessed its impact from a healthcare perspective. The researchers used the 2018 US Census data on adults aged 18 and older who had a dental visit with an antibiotic prescribed, and on the reported incidence of infective endocarditis among those without predisposing cardiac conditions who underwent dental procedures. Inappropriate dental antibiotic prescriptions to prevent infective endocarditis resulted in approximately 31 million in excess costs to the healthcare system and clients annually. And this included out-of-pocket costs, drug costs, and adverse event costs of almost 6 million for amoxicillin, 2 million for clindamycin, and 380,000 for cephalexin. Addressing the issues of inappropriate antibiotic use in dentistry is crucial to reduce the burden of preventable adverse effects, healthcare costs, and downstream antibiotic resistance. So it's important to note that clindamycin was removed from the 21 update for American Heart Association infective endocarditis prophylaxis guidelines. Clindamycin may cause more frequent and severe reactions than other antibiotics used for antibiotic prophylaxis. Clindamycin substantially increases the risk of developing C. difficile infection even after a single dose.
Just as an FYI, symptoms of C. difficile include watery diarrhea, fever, loss of appetite, nausea, abdominal pain and tenderness. It can also cause life-threatening pseudomembranous colitis, bowel perforation, sepsis, and death. So antibiotic prescribing by dentists can be influenced by client pressure. A recent study evaluated dentists prescribing antibiotics habits and the frequency of facing client pressure for prescriptions. 1/3 of participants reported being pressured by clients to prescribe unnecessary antibiotics more than once a week, while 22% reported that parents pressured them to prescribe unnecessary antibiotics for their children. The authors recommend educating dentists on how to respond to clients' requests for antibiotic prescription to minimize unnecessary antibiotic use. So Dr. Glogauer, do you have many clients who insist on receiving antibiotics unnecessarily, and how do you handle that request?
So I do, and my approach is as follows. I explain to them that antibiotics, I explain to them the issue of AMR, and I explain to them that there may come a time that you absolutely need an antibiotic for a severe infection. And if we've given you antibiotics when they're not needed, you may develop AMR so that when you really need it in a potentially life-threatening situation, it won't work. And I said, you have to, based on my clinical expertise and training, you do not need an antibiotic in this case. And if I were you, I would strongly insist that we save the antibiotics for when you may potentially need them. And for most patients, that works. It doesn't work for all of them, but for most of them, it does work.
Yeah.
So yeah, so I think it's important. I mean, we clinicians, we need to be able to educate our patients so that optimal treatment is provided, and that we don't irresponsibly use some of the tools we have in situations when they're no longer when they're so that we have them when they're needed. So
Absolutely. Yeah.
in
Because
terms of,
I know of people that if they go to an appointment and if they don't come back with a prescription, they feel they're not being treated.
yeah, yeah, and that it's our job to get it right. So in terms of ineffective usage of the healthcare system for non-traumatic dental conditions, research has shown a significant number of people in Canada, including Ontario, visit physicians' offices and emergency departments for their dental concerns. And people seeking care for non-traumatic dental conditions from these settings usually receive only prescription medications, including antibiotics and opioids, which most often do not address the cause of the problem. And the clinical situation may worsen from delayed treatment and repeated antimicrobial usage, requiring even more specialized care. And this is a problem with our healthcare system, and the way it's designed. Individuals who are also at risk of developing resistance to antimicrobials so again, individuals are at risk of developing antimicrobial resistance and dependence on pain medications, which can be even a bigger issue. Now, in terms of oral health care and COVID-19, the pandemic had a profound effect on oral health care worldwide. It led to the deferring of care during the early months of the pandemic and created a huge backlog of needed oral health care. During the months of virtual triage or office closures, with only the most urgent care being provided, including antibiotics, which were used in these situations, has sort of compounded the problem. So, for example, studies have reported restricted access to oral health care due to COVID-19, which resulted in greatly increased dental antibiotic prescribing in England against an otherwise downward trend. So the reasons for increased prescribing were probably multifactorial, adding that swelling and pain were the most common primary reasons for antibiotic dispensing, and that dentists may have felt less confident diagnosing and treating acute pain remotely. During the first wave of COVID-19 in Alberta, we saw a reduced provision of oral health procedures, which was accompanied by an increase in drug prescribing. And the leading drug prescription increases occurred during the April-May of 2020, when access to care was mostly restricted, with antibiotics at 300% and non-opioid analgesics at about 740% higher than the same time in 2019. And I should add that, that pandemic, we're still seeing the effects of it. And last year, I saw 2 patients who had oral infections that spread to their spinal cords and brain within the hospital. And unfortunately, one of those patients actually died. And this was an example of where they had we noted severe periodontal disease that was not treated. This person never ended up going back to their dentist. I still see patients today who are coming to the dentist for the first time, mainly out of fear of contracting COVID. So there's still isolated pockets of patients out there who have been so traumatized by the pandemic that they still haven't been seeking regular dental care.
Yeah, I think we'll see more research in the future to see how much more antimicrobial resistance the pandemic has created. So Mian et al. In 2021 investigated prescribing trends for dental medications in Australia over the COVID pandemic. Total prescriptions during the lockdown period fell, reflecting a reduction in total oral healthcare visits. Use of antibiotics and opioid analgesics during this period remained relatively high, consistent with the increased use of these medications as an alternative route to operative treatment to reduce the COVID. They weren't going in to get treatment done because of the chance of transmitting COVID. So following easing of the service restriction, prescriptions for broad spectrum antibiotics and opioid analgesics increased, which may have reflected the clinical deterioration from delayed treatment from the lockdown period. So overall, dentist-driven prescriptions added to the global increase in antibiotic prescribing as a result of the pandemic. So what's going on with the oral impact of AMR?
So a recent study in 21 showed that isolated bacterial pathogens from individuals with odontogenic infections and analyzed their resistance to antibiotics, and observed that the most frequently found microorganisms, which are Streptococcus species and Staphylococcus species, were resistant to penicillin and aminopenicillin in 7% and 6% of the strains, respectively. In addition, more than 17% showed resistance to clindamycin and macrolide antibiotics, and the substantial antibiotic resistance observed in isolates from odontogenic infections calls for strengthened efforts in antibiotic stewardship and infection prevention and control measures in oral healthcare. Clindamycin has been used in dentistry for decades to treat P. gingivalis-related conditions, from periodontitis to periodontal abscesses. However, evidence collected over 20 years shows that P. gingivalis may be developing resistance to these antibiotics. Rems et al. In 23 evaluated pre-treatment subgingival biofilms from 3 sets of US participants with severe periodontitis from 3 different time periods, 1999 to 2000, 2009 to 2010, and 2019 to 2020. And they showed that clindamycin resistant P. gingivalis increased significantly from 0.6% in the first time cohort to 9.3%, a 15-fold increase in the last subset. P. gingivalis resistance to amoxicillin also significantly increased from 0.1% of participants in the first cohort to 3% in the last cohort, which is a 28-fold increase. And P. gingivalis resistance to metronidazole, metronidazole plus amoxicillin and doxycycline was very low at less than 0.5% prevalence and statistically unchanged over the 20-year period. So the authors noted that the prevalence of antibiotic-resistant P. gingivalis and other periodontal pathogens varies considerably between the countries and geographic regions, underscoring the need for region-specific monitoring of antibiotic resistance trends among periodontopathic bacterial species. The authors concluded that increased antibiotic resistance of P. gingivalis and other periodontitis-associated bacteria threatens the efficacy of periodontal antimicrobial therapy.
So D'Ambrosio et al. In 2022 evaluated the adherence to oral antibiotic therapy and AMR awareness among dental clients. So dental clients generally showed a low 52% adherence to oral antibiotic therapy, and medium and high adherence was reported only by 29% and 19%, respectively, of those participants. Levels of adherence to antibiotic therapy was positively associated with higher education. Antimicrobial resistance awareness was higher in the young participants, approximately 18 to 36 years old, and was positively associated with higher education. Given the adherence to antibiotic treatment is necessary to make therapy effective and to reduce the impact of AMR, interventions to increase the client's knowledge of antibiotic therapy and antimicrobial resistance may improve their adherence to treatment. However, the term antimicrobial resistance had little meaning to the public and may need to be renamed according to a recent study that was done in 2023. The study looked at word memorability and risk association for 6 most frequently used terms to describe antimicrobial resistance, including antimicrobial resistance, AMR, antibiotic resistance, bacterial resistance, drug-resistant infections, and superbugs. A total of 237 US and 924 UK participants were tested on memory for and the risk they associated with each term on a scale ranging from very safe to very risky. So results showed that the term AMR and the term antimicrobial resistance were among the lowest scoring terms for both risk association and memorability, and therefore unsuitable for public health communication. However, the terms antibiotic resistance and to a lesser extent drug-resistant infections performed better. Participants generally found it difficult to remember words associated with AMR and did not think they sounded risky compared to other health risk words. Future risk communications may benefit from renaming AMR to better signal the severity of the problem and motivate behavioral change. So let's talk about chlorhexidine.
So chlorhexidine is a widely used biocide in clinical and household settings, and it's a bisguanide agent with broad spectrum antimicrobial activity against gram-positive and negative bacteria, plus fungi and certain viruses. The antimicrobial effect of chlorhexidine is dose-dependent, being bacteriostatic in that it inhibits bacterial growth at low concentrations, 0.02 to 0.06%, and bactericidal at high concentrations above 0.1%. It's used in medicine for preoperative skin disinfection, decontamination of skin and mucous membranes in intensive care units, impregnation of medical devices such as catheters, and disinfection of inanimate surfaces. In addition, chlorhexidine is used in oral healthcare mouth rinses at 0.12% to 2.2%, toothpaste, gels, varnishes, and sprays. Chlorhexidine mouth rinse is one of the most used mouth rinses in oral healthcare to reduce the bacterial load in the oral cavity to control or prevent oral infections. Chlorhexidine exerts its bacterial properties through an increase in cell membrane permeability, which causes lysis and the loss of intracellular material and the eventual death of the bacterial species. Research has shown no significant changes in bacterial sensitivity, overgrowth of potentially opportunistic organisms, or other adverse changes in the oral microbial flora following the use of chlorhexidine. Mouth rinses at 0.12% for 6 months. 3 months after use was discontinued, the number of bacteria in the plaque had returned to pre-treatment levels, and sensitivity of plaque to chlorhexidine remained unchanged. However, studies over the last few decades have reported that chlorhexidine resistance in different bacterial species, but at concentrations well below those used in the clinical setting. Meanwhile, studies of in vitro chlorhexidine-adapted bacteria have reported cross-resistance between chlorhexidine and other antimicrobials, while clinical studies to support the hypothesis of chlorhexidine cross-resistance with antibiotics are currently lacking. It's important that oral healthcare practitioners understand that appropriate clinical use of chlorhexidine should be oral disease specific.
So let's talk about triclosan. So triclosan is a broad-spectrum antimicrobial additive, and it's added to a wide range of consumer products such as hand sanitizers, fragrances, deodorant, eye and face makeup, natural health products, toothpaste and mouthwash, soaps, skin cleansers, lotions, and shampoos. The reason why it's added is because it acts as a preservative, it helps to prevent odors, it kills bacteria, and it stops the growth of bacteria and fungus in the products, or if they're using it for like a disinfectant. So Canada regulates cosmetics, non-prescription drugs, and natural health products. The maximum amount that Canada allows in triclosan is 0.03% in mouthwashes, 1% in non-prescription drugs, and 0.3% in cosmetics and natural health products. In 2016, Health Canada assessed the potential health and environmental risks of triclosan. From the assessment, they found that triclosan poses a risk to the environment when products containing triclosan, for example, toothpaste and soap, are washed down the drain. The amount of triclosan that is released can pose a risk to plants, fish, animals, all that aquatic life in lakes, streams, and rivers. It affects their growth, reproduction, and survival. The government found no clear link between use of the products containing triclosan and antibacterial resistance. However, a recent study in 2022 by University of Toronto researchers found triclosan could be contributing to antibiotic resistance in Canada. The study investigated sewage sludge from Ontario's sewage treatment plants and found triclosan was the predominant antibacterial compound impacting E. coli. Sewage treatment plants are a breeding ground for antibiotic-resistant bacteria due to the diverse set of antibiotics found there. So products containing antibiotic ingredients are rinsed down the drain and transported to sewage treatment plants where they accumulate and may interact with bacteria and cause the development of antibiotic resistance. And if we look at the United States Food and Drug Association in 2016, they banned triclosan from being used in antibacterial liquid soaps, and then a year later from being used in topical antiseptics found in healthcare settings. Currently, there's limited regulations on triclosan in Canada, and Health Canada still deems triclosan as safe for the use in a variety of consumer products at specified levels. So the results of the study, the UFT study we were just talking about, the Ontario study, demonstrate the urgent need for regulatory agencies in Canada to reevaluate the use of triclosan. So tell us about Staphylococcus aureus.
So Staphylococci are gram-positive aerobic organisms, and the genus consists of 70 species and subspecies, from which the majority are common colonizers of skin, mucous membrane of the nose and the mouth. So Staph aureus is the most pathogenic Staphylococci bacteria, and it's considered a high priority pathogen by the WHO, in which new antibiotics are urgently needed due to causing severe infections worldwide and to the rise of an emergence of strains resistant to clinically relevant antibiotics. So S. aureus typically causes skin infections, such as folliculitis and impetigo, and often causes abscesses. S. aureus can also cause pneumonia, endocarditis, osteomyelitis, septicemia, sepsis, and death. And the bacteria also tend to accumulate on medical devices in the body, such as artificial heart valves and joints, pacemakers, catheters, which are inserted through the skin into blood vessels. Treatment is usually with penicillinase-resistant beta-lactams, but because antibiotic resistance is common, vancomycin and other newer antibiotics may be required. Usually, infected bone and foreign materials have to be removed surgically to cure the infection. Abscesses at present are usually drained. A carrier state is common, and the carriers are the people who have the bacteria but do not have signs of infection, and the bacteria are carried in the anterior nares, which is of the nose, of about 30% of people, and on the skin about 20% of the time. From these locations, staph can cause infections in the host and others. Carriage rates are higher in hospitalized patients and hospital personnel. S. aureus infections are more prevalent in carriers than in non-carriers, and S. aureus occurs in up to 50% of the carriers and frequently becomes resistant. Many S. aureus strains have developed resistance to antibiotics, and if carriers take antibiotics, the antibiotic kill the strain that are not resistant, leaving mainly the resistant strains. Methicillin-resistant Staph aureus, or MRSA, is used to describe strains of S. aureus that have acquired resistance to beta-lactam antibiotics, and about 2% of people carry MRSA. MRSA strains are common in healthcare-acquired nosocomial infections. Some strains of MRSA cause community-acquired infections, including mild abscesses and skin infections that may look like a pimple or a boil, which can be red, swollen, painful, or have pus or other drainage. And community-acquired infections are becoming more and more common. MRSA can spread by direct contact with an infected person or via contaminated objects, and or less often by inhaling infected droplets dispersed by sneezing or coughing. And in healthcare settings, MRSA is typically spread from patient to patient on unclean hands of healthcare personnel or through the improper use or reuse of equipment. And if you recall, when we talked with Dr. Barbour about our new probiotic strain that we've identified, which looks very promising against treating periodontal disease. It also is able to kill MRSA bacteria, so that's very promising.
And we'll be talking about that research more in a minute. So risk factors for MRSA include a history of MRSA infection or colonization. I remember having a client that had MRSA on his face. It was clear what time he came back in, but it took a long time to get rid of, and he's at risk to get it again. So other risk factors for MRSA include recent and or frequent antibiotic use. Sports participants who have skin-to-skin contact, skin damage, sharing clothing or sharing the gym equipment. So important to wipe off that equipment. Living in crowded or unsanitary conditions, men who have sex with men, injection drug use, hospitalization, having an invasive medical device, for example, an intravenous line or a urinary catheter, residing in long-term care facilities, close contact with someone known to be infected or colonized with MRSA, and recurrent skin disease. Preventing healthcare association MRSA, you need to ensure appropriate hand hygiene. That's either the soap and water or an alcohol-based hand sanitizer, along with other appropriate infection control practices. In some healthcare facilities, people are routinely screened for MRSA when they are admitted. Some facilities only screen those at increased risk for MRSA infection. For example, they're having some prior to having a certain operation done. Screening involves testing with a nasal swab sample. If MRSA strains are detected, people are isolated to prevent spread of the bacteria until the infection is cured. So preventing community-associated MRSA includes practicing that thorough hand hygiene, avoiding sharing personal items, towels, razors, etc., showering after exercising or participating in sports, keeping cuts, scrapes, and wounds cleaned and covered until they're healed, and seeing a medical provider for early diagnosis and treatment if an infection is suspected. So what about MRSA in the oral cavity?
So S. aureus is considered a commensal as well as a pathogen, and as a commensal, S. aureus is principally isolated from the anterior nares, although it colonizes other anatomical sites, including the oral cavity and tonsillar crypts. Oral S. aureus may originate in the oral cavity, or they could transit to the mouth from the nares via the oropharynx. Prevalence of oral S. aureus tends to vary by population. Reports indicate somewhere between 25 and 85% in healthy dentate adults and about 50% in denture wearers. Reports indicate high S. aureus and MRSA carriage rates in the oral cavity, although it's unclear whether these reported high rates are due to increased focus on S. aureus and MRSA. MRSA oral carriage may constitute a reservoir for subsequent colonization of other body sites or for cross-infection to other people. Evidence from several studies indicate that MRSA appears to preferentially colonize denture surfaces, which then may act as a source of infection to distant sites, such as for aspiration pneumonia, cross-infection, or recolonization. MRSA organisms are sometimes very difficult to eradicate from dentures, requiring certain antimicrobial agents, for example, 2% chlorhexidine to eradicate from dentures, requiring certain example, 2% chlorhexidine or 1% sodium hypochlorite, including microwave irradiation or fabrication of new prostheses. So just to make you aware, sodium hypochlorite could bleach denture acrylic resin and corrode the metal parts. However, short immersion times of about 1 minute can eliminate MRSA biofilms, as shown by Lee et al. In 2009. Dentures must be submerged in a container full of water. Dentures with metal should never be microwaved. Microwave irradiation at 650 watts for 3 minutes could work as well. And I think it's important to speak to a dental technologist or denturist who fabricated the dentures to determine what is the optimal way to decontaminate the denture. It also may be useful to speak to dental supply companies who provide denture cleansers to find out which one may be ideal to eliminate MRSA. Research involving an elderly veteran population in an extended care facility demonstrated that 20% had MRSA oral carriage, whereas 20% were nasal carriers. Of interest, 4% of the proven MRSA oral carriers were culture negative for nasal carriage. This observation partly explains why decolonization exercises that target nasal carriage alone may fail. S. aureus is implicated in several infective oral pathologies, including angular colitis, parotitis, mucositis, and also in dental implant failure. Generally, very few studies have reported on MRSA clinical infections in the oral cavity and were inconclusive as to whether the isolation of MRSA reflected disease or carriage.
So I said we talk about vaccines. So addressing AMR begins with preventing infections. So vaccines are important to fight against antimicrobial resistance. Vaccines directly block the transmission of pathogens that cause infections. Decreasing transmission decreases the number of infections and reduces the chance of a pathogen mutating to a drug-resistant form. In addition, people protected by vaccines are less likely to get as sick as often, which helps reduce the overall consumption of antibiotics. Since antibiotics are often inappropriately prescribed for viral infections, for example, it's no sense taking it for the influenza, vaccines against these viral infections could reduce inappropriate antibiotic use and help prevent AMR. Vaccines as a tool to reduce AMR has been well established. For example, in the Haemophilus influenza type B, the Hib and the Staphylococcus pneumoniae, conjugate vaccines not only prevent life-threatening diseases caused by these, but they also reduce antibiotic use and AMR. And in the keynotes, we've included several papers discussing the role of vaccines in combating antimicrobial resistance if you want to read a little bit more about it. So we know that the vaccines are good. They're going to help with the AMR, but the problem is there's vaccine hesitancy. The WHO recognizes vaccine hesitancy as one of the 10 major global public health threats. Vaccine hesitancy, which is the reluctance or refusal to vaccinate despite the availability of vaccines. And this threatens to reverse progress made in tackling vaccine preventable diseases. Vaccination is one of the most cost-effective ways in avoiding disease. It currently prevents 2 to 3 million deaths a year, and a further 1.5 million could be avoided if global coverage of vaccinations improved. Reasons why people choose not to vaccinate are very complex. For example, there's complacency. It's the inconvenience of accessing vaccines. It's the lack of confidence towards the vaccines. These are some of the key reasons underlying hesitancy. Healthcare workers remain the most trusted advisor and influencer of vaccination decisions, and that includes us dental hygienists and dentists. So let's talk about the role of oral health practitioners. Oral health practitioners have the potential to assist in vaccine education. A recent study by Steinbaum et al. In 2023 assessed clients' attitudes towards oral health care providers' roles in HPV and vaccinations. This study verified clients' willingness to consider education, the recommendations, and administration of vaccines from oral health practitioners, especially when you were talking about the COVID-19 and HPV vaccinations. Research also has shown parents are comfortable discussing vaccines available for the children with both their child's dentist and their dental hygienist. Oral health practitioners are trusted healthcare professionals, as I said, poised to make a positive impact on youth vaccination programs. Overall, oral health practitioners have the opportunity to support clients and provide a larger platform for vaccine education. So let's talk about tackling AMR in oral health care.
So there are opportunities for the oral health team to tackle AR, and these would include educating clients, families, and friends on how to reduce getting sick. In the keynotes, we provide client resources to share on this topic. We can also raise client and public awareness and the understanding about AMR, including responsible use of antibiotics. We can prevent infections by increasing vaccine uptake through client education. We can reduce the incidence of oral infections through client education on oral self-care, healthy eating, and oral disease prevention. We can advocate for reduced sugar consumption and water fluoridation programs to help reduce dental caries. We can encourage early diagnosis and treatment of oral diseases to prevent infections and reduce the need for antibiotics. We can optimize antibiotic use through effective stewardship. We can educate medical professionals on antibiotic prophylaxis for oral care procedures. And what I mean by this is many orthopedic surgeons may not even be aware that antibiotic prophylaxis is not required after, for example, knee and hip surgeries. And many of them are unaware of this or ignore this point. Utilizing effective infection prevention and control measures in oral health care, so for example, hand hygiene, PPE, sterilization of equipment, appropriate handling of contaminated equipment, etc., is very important.
So let's talk about the responsible use of antibiotics. We've got to remind clients that not all illnesses can or should be treated with antibiotics. If an antibiotic is prescribed, though, we can recommend them to use it responsibly. For example, take the antibiotics only as directed by the healthcare provider. For example, remind them when to take it, the correct dosage, and for how long, and to complete the antibiotic treatment, even if they start to feel better, because this will help prevent the emergence of resistance. Because if they only take it for a short period of time, they haven't eradicated that bacteria, you leave some behind that become resistant. And if they've been told to stop taking the antibiotics by an oral health care provider, that they should return the unused antibiotics to a pharmacy for safe disposal, because we talked about the ones they were treating those leftover antibiotics like gold. So they had it, they were so excited to have it. So we don't want to use any leftover antibiotics. We don't want to share them with anyone or use antibiotics for prescribed for someone else. And then also, if they have a bad reaction or side effect, they should tell their healthcare provider, because it may not be allergic reaction. I know that people end up getting sometimes a rash, and it's not related to a reaction, it's related to a virus they actually had. So let's talk about, so what actually is antimicrobial stewardship? Give us a reminder.
So this is the appropriate use of antimicrobials to optimize clinical outcomes, combat resistant infections, avoid adverse drug events, and minimize costs. It means prescribing the right antimicrobial only when needed for as long as needed. And an accurate diagnosis should be obtained, and the specific antibiotic for that bacterium causing the infection should be used rather than broad spectrum antibiotics. And the appropriate doses should be used for the shortest possible time required to eliminate the bacteria causing the infection to help lessen the risk of AMR, as well as reduce the side effects and the costs. Now, evidence-based guidelines by the American Dental Association have been developed to optimize the antibiotic use for the urgent management of pulpal and periapical related dental pain and swelling. And the key points of the guideline include not using antibiotics for most pulpal and periapical conditions, and instead recommend only using dental treatment, and if needed, over-the-counter pain relievers such as acetaminophen or ibuprofen. Instead of prescribing antibiotics, prioritize dental treatment such as pulpotomy, pulpectomy, non-surgical root canal treatment, or incision and drainage for symptomatic irreversible pulpitis, symptomatic apical periodontitis, and localized acute apical abscesses in adult clients who are not severely immunocompromised. Prescribing antibiotics if a client's condition progresses to systemic involvement showing signs of fever or malaise. And the European Federation of Periodontology S3 level clinical practice guideline for the treatment of stage 1 through 3 periodontitis due to concerns about client health and impact of systemic antibiotic use to public health. The routine use of antibiotics as an adjunct to subgingival debridement in clients with periodontitis is not recommended. Based on the available evidence, the adjunctive use of systemic antibiotics may be considered for specific client categories, such as generalized stage 3 in young adults. However, these clients should be referred to a periodontist if systemic antibiotics are being considered.
So when do you prescribe antibiotics for, say, implants, periodontal disease, extractions?
So I would say that I'm very judicious, very careful in the prescribing of antibiotics, and really look at the patient's medical history, their overall health, and the nature of the infection to determine whether antibiotics are required. And I must say, over the past 10 years, I've becoming much more conservative in the prescribing of antibiotics, because I'm aware and I've seen enough patients who've ended up in hospital with C. difficile that I'm very, very careful, because I definitely don't want to cause harm in these patients. And a C. difficile infection that requires hospitalization, you can have somebody in the hospital from 2 to 6 months, and it's very, very debilitating. So it's critically important that we're very, very careful about how we prescribe.
And as an FYI, the World Health Organization developed the Access, Watch, Reserve, called AWARE, antibiotic book to improve antimicrobial use in humans globally. The publication contains evidence-based guidance on the optimum treatment for over 30 common infections, including when antibiotics are not needed. And just as interest's sake, the book has a chapter on oral and dental infections for those of you who want to expand your knowledge on this topic. We have provided the link to this book in the keynotes. So now there's need for some novel research, some new research, and integrated strategies required to combat AMR effectively. And this includes developing novel antibiotics, next generation vaccines, for example, vaccines using novel adjuvants to improve immune response, They need to develop some rapid diagnostic tools to identify the cause of the microbial infection and to determine antimicrobial susceptibility to inform the appropriate treatment strategy. There's also monoclonal antibodies could offer an effective way to address bacterial infections by targeting molecules specific only for pathogenic bacteria, safeguarding the microbiota, and then also activating the body's immune system, resulting in a more broader and more effective immune response, and reducing the toxicity associated with high doses of antibiotics. There could also be some, we need to look into the microbiota interventions to establish a healthy microbiome, because when you got a healthy microbiome, it helps prevent the opportunistic bacteria from causing infections. It balances it out. And then there's also the bacterial phages or phages. And this is a highly specific, phages are highly specific viruses that infect bacteria. So phage therapy is the use of active phages to kill bacteria that cause human diseases while leaving other bacteria unaffected, the good bacteria unaffected. Phage therapy has the potential to tackle AMR and emerging infectious diseases. And in episode 98, we interviewed Dr. Babur on commensal oral bacteria with probiotic and antibiotic properties. And this was research done by Dr. Babur, our own Dr. Glogauer, and colleagues. So why is this research important for AMR? So
the new biotherapeutic molecule patented as salivarisin 10 or Sali-10 is produced by a strain of Strep salivarius. So it's a probiotic strain that kills infectious pathogens while promoting a healthy microbiome. So it's very targeted. It's not broad spectrum. And this provides opportunity for an alternative to conventional antibiotic treatments and is a novel solution to prevent infectious diseases. The combined peptides of Sali-10 exhibit very potent antimicrobial activity against a wide range of gram-negative bacteria, including opportunistic pathogens such as multi-drug resistant strep pneumonia, strep pyogenes, strep agalactia, vancomycin-resistant Enterococcus faecium, and multi-drug resistant Enterococcus faecalis clinical isolates. And importantly, Sali-10 also possessed antibacterial activity against selective gram-negative disease-associated bacteria, including P. gingivalis, Tannerella forsythia, and Neisseria gonorrhea.
So where are you hoping now with this Sali-10? Where are you taking it now?
So we're just about, probably in the next 3 or 4 months, we're going to start clinical trials showing how it prevents periodontal disease and gingivitis, but at the same time also demonstrate how it reduces targeted bacterial burden. And in addition, we believe, because it doesn't carry any bacterial antibiotic resistance elements, we think that we can actually remove bacteria that are resistant to antibiotics within the commensal bacteria, within the bacteria within the oral microbiome. So we're going to be carrying out these studies over the next 3 to 6 months, and we're hoping that we will be close to market in less than a year.
Oh, exciting. We'll be talking about this topic again. So Dr. Glogauer, what are our take-home messages for today?
So AMR threatens the effective prevention and treatment of an increasing range of infections, and the inability to treat these infections results in increased illness, deaths, and makes routine medical procedures riskier. Treating resistant infections also has an economic consequence, including increased healthcare costs, prolonged hospital stays, and time off work. The potential benefit of antibiotic administration must be weighed against the risk of side effects, such as severe allergic reactions, anaphylaxis, and infections caused by C. difficile. Now, exposing clients to antibiotics when not necessary, in other words, the just-in-case type of prescribing rationale, increases the risk that antibiotics will fail when they're truly necessary. And it also increases the risk that bacteria resistant to antibiotics will spread to clients' families, friends, and others. Before every decision to prescribe antibiotics, care must be taken to assess the risk of antibiotic resistance developing for the individual client, as well as spreading more widely across society. And finally, preventing oral infections raising awareness about antibiotic resistance and optimizing the use of antibiotics through stewardship, the oral health professionals can protect individual clients and society in general.
Excellent. And I'm going to remind everybody to submit your comments, questions, and topics to ODHA for future conversations. And join us next time when we'll be discussing smoking cessation. This has been Dr. Glogauer and Kim Ivan, sharing research to enhance your evidence-based practice.